Welcome back, everyone. My name is Andrea McMillan. I'm part of the planning group for this, and I'd like to introduce our next two speakers, Dr. Candice Moran and Dr. Danyele Shelton. They're both licensed psychologists at KUMC, working specifically with the Counseling and Educational Support Services Office, which provides services to the med students, all students at KUMC, residents and fellows as well. Dr. Moran focuses on LGBTQIA+ issues, therapy, and inclusive environments, and is co-chair of our Prism group, which is our LGBTQIA+ affinity group, thank you, at KUMC, which I also am part of and cannot pronounce. Dr. Danyele Shelton focuses on dual roles, both as the co-chair of the DEI Programming Committee and is a member of the DEI Cabinet. And I think they're both fantastic human beings, so I'm happy to have them here.
All right. Well, thank you so much, Andrea, for that beautiful introduction. So as she mentioned, I'm Dr. Shelton and with Dr. Moran, and our focus for today is going to be on obviously suicide prevention, consistent with the theme, but it'll have more of an emphasis on culturally informed suicide prevention. The reality is everyone is not the same. You know, everyone comes from different backgrounds, cultural backgrounds. And that means we have to be a bit flexible about our approach with people. We can't, sure, there's certain steps and factors we want to keep in mind, but it can't be a one size fits all. So, you know, our goal with this presentation is to be mindful of that and talk about those cultural factors and how we could maybe adjust our approach.
So some of the things we'll be talking about are similar to the previous presentation. We're just going to kind of dive a little bit deeper into how this might show up for specific cultural groups and individuals of various identities. Once again, cultural communities, various and folks of various identity backgrounds, not a monolith. So this is not going to apply to everyone, but it's some considerations to think about when you're approaching the individual that you're working with, or when you're thinking about any sort of prevention strategies and what this looks like. My pronouns are they, them, theirs. So if you were talking about me, you would say Candice went to the store, they got a gallon of milk and a dozen eggs and brought it back to their house with them. Any questions about that? Okay, awesome. Just to kind of position myself a little bit, I am a queer non-binary person. I'm white. I am from the Midwest. I grew up in Kirksville, Missouri, if any of y'all know where that is. And that kind of influences a little bit of how I approach these topics and how I think about these things. So I feel like it's important for me to share.
Thank you for sharing. And I think both of us are very committed to diversity, equity, and inclusion. Both of us do a lot of work around that at KU Med. Obviously, I am a woman. I am a Black woman specifically. I have family in the South, even though I was raised all over the place, but I identify with Southern ideals. So, can you hear me very well? Okay. Can you hear me better now? All right. I'll be mindful of that moving forward. But anyway, that's just an introduction of us. And so we are going to delve into it here. All right. So kind of going back to what our objectives are, we want to look at like relevant cultural factors that impact suicide risk factors. So we have an idea of what kind of those basic risk factors are, or general risk factors are, but we're going to look at it more within the framework of other cultural factors that influence that. Okay. We're going to identify and recognize suicidal signs in yourself and others, and how those present in diverse populations, okay? And build skills to respond in culturally sensitive ways.
You want to talk about okay. So just some general statistics, which may have already been covered in previous presentations, but suicide was among the top 9 leading causes of death for people ages 10 to 64 in 2021. And specifically looking at ages 10 to 14, so kind of that pre-adolescence, early adolescence, it's the second leading cause of death and third leading cause of death for that kind of late adolescence, early adulthood, 15 to 24. And we do know that 46% or, this is hard sometimes to look at retroactively, but around half or a little less than half of people who do die by suicide had a diagnosed mental health condition prior to their death. Although looking at reports from family members and medical records, history, and things like that, research believes that it's actually probably closer to 90% of folks who die by suicide have experienced some symptoms of mental health conditions at some point in their life. And this is not something that is infrequent. It's not something you're going to come across, or it's not something you're not going to come across. As we know, suicide is something that impacts all individuals, all cultures, all backgrounds, but it might show up in different ways and it might have different impacts. So that's one of the things that we're going to talk about today.
Okay. So being a bit more specific and breaking down suicide rates by group, you'll see that for non-Hispanic American Indian, Alaskan Native individuals have the highest suicide rates when you're breaking it down by racial ethnic groups. And that's significant because we want to have an idea of what rates look like depending on who's in front of you, just to get a general sense. And obviously it informs prevention efforts too.
And it's important to note that these categories were the ones designated by the CDC. These are not how we are designating them.
Exactly. Okay. And there are high-risk groups, and that varies. And so when we think of culture, sometimes people look at it very narrowly and think of racial, ethnic background, but there are a whole lot of different ways that you can view culture. So for example, veterans are their own unique culture, and they also happen to be a high-risk group for death by suicide. So we're wanting you to kind of look at it from that framework, like what are those different factors of a person's identity that comprises their culture, okay? So as you can see, there are a number of groups, unfortunately, that are high risk. And again, it's important to be mindful of this because whoever's in front of you, if one of these identities align with them or multiple, that's something to be mindful of.
If you look on here, people in rural areas are a higher risk category. And I think for most of us, we work with folks from rural areas, whether that's rural Kansas, rural Missouri, or elsewhere. And there are ideas behind why some of these groups might be at higher risk, and there are definitely factors, but we don't know for sure, okay? It's also important to note that suicide rate among males was about 4 times higher than other genders. This is talking specifically about completed suicide. It's not necessarily talking about attempted suicide or suicidal ideation. Any questions on the stuff we've briefly covered so far? Awesome. Also, I talk with my hands a lot. My watch tells me I get a dynamic workout when I present. If that is distracting to anybody, please let me know and I will try and hold it in. But my neurodivergent self just does that a lot. So fair warning. Okay. One of the things we also look at, especially in the setting that we work in, but also it's important for all of y'all to keep in mind that one of the cultures is also healthcare providers. Exactly. And we know that the rates of suicide for healthcare providers, especially, this has been highlighted within the last few years, is extremely elevated. And we don't always have the best data, in part because of some of the things that were mentioned in the previous presentation. Stigma, whether families are reporting that, whether the person is reporting that or not. And there's a lot of cultural factors influencing healthcare providers as far as help-seeking behaviors, burnout. There's a lot of stuff out there. So are any of y'all familiar with the Lorna Breen Project? Okay, so there is, in some states across the United States, there are questions on physicians' renewal of their licensure that asks about, have you sought mental health treatment or things like that, which in some states really increases the fear of seeking help and reporting that because it could cost you your insurability, your livelihood, your career that you have worked very hard for, spent a lot of time and a lot of money doing. And so the Lorna Breen Foundation was formed after a physician died by suicide for a lot of these same reasons. And this was somebody who was working in the ERs during the height of COVID. And her family and friends have made it their mission to try and change these questions across the United States. And so if you're not familiar with it, I'd encourage you to check it out. Kansas does have, has made some changes to the language that we use, but that's not just for physicians. That stigma applies across the board. I mean, even for us as psychologists, there is concerns about what if I'm seen as an impaired professional? Will that influence things? Will people see me as capable of helping others with their mental health if I admit that my mental health is struggling?
So for this culture, it's important to keep in mind that there is a lot of concern about the implications of seeking help. That is a very unique barrier for healthcare providers because, as Dr. Moran mentioned, people work very hard for a very long time to achieve in their chosen areas. And there is fear about what will happen if people know not only that I'm seeking help, but that I'm experiencing suicidal ideation. And that contributes to maybe an attempt or, you know, so.
And especially within the last few years, there's been this hero persona and mentality of healthcare providers, which also reinforces that stigma of admitting that we're struggling or that this is hard, when in reality, we are humans. And so if it didn't impact you in one way or another, I would be surprised. Okay, so it's also important to, when we're thinking about suicide prevention and these risk factors and these warning signs, that we're not just thinking about the patients or the clients that we work with, but we're also thinking about our colleagues, our friends, the people we see in the hallways, the people in our life outside of work. Like I said, suicide impacts us all. And so it's important to keep that in mind as we go through the world and through our day. So we've got some statistics here. Once again, statistics are hard to get on this, in part because we are looking after the fact. Okay. But here's some statistics. There's lots more out there. And especially, they've started to do a little bit more research looking at this, especially post the start of the pandemic, seeing the impact of these horrible working conditions, the burnout and things like that.
All right, so again, some of this may be a bit of a repeat of like the previous presentation, but I think it's very important to break down what we're referring to. What is suicidal distress? Well, there are kind of three main categories, right? So there's ideation, you're thinking about it, and this could be passive or active, and it's important to make that distinction, right? So passive would be, you know, maybe you're having thoughts of death or escaping whatever you're experiencing, but not really having a specific plan or not really intending to harm yourself or attempt suicide. Versus active, you're actually having thoughts about self-inflicted death, okay? And maybe even thoughts about a plan, right? Obviously, an attempt is any self-directed act intended to end your life. And then, you know, we have, unfortunately, death by suicide or suicidal death. And that is someone who has engaged in a self-directed act that resulted in taking their own life. Okay.
And it's important that you're able to communicate that you understand the difference between these, because especially for certain communities and certain, you know, age demographics or things like that, there's a fear that if I say that I've had thoughts of suicide or that I'm afraid that I might get there, or I'm thinking about, is life worth living? They're afraid that if I mention that to anybody, anybody heard this phrase, grippy sock vacation? Okay, if you haven't, anybody probably 25 and under is familiar with that, especially if they're on social media and TikTok. But it's the idea that if I admit anything in this area, I'm going to end up in the hospital. I'm
Yeah.
going to have something done against my will. I'm going to this extreme revocation of my autonomy.
Yeah.
And so it's also important to acknowledge to people that this isn't all the same thing, and that as much as you're able to, that you either you personally or you can put them in touch with a mental health provider who knows that and
To
can
make
help
those
them go a little deeper and piece that apart so they can actually get the assistance that they need in that moment or in that short term.
Yeah, and obviously with certain cultures, there's increased fear about acknowledging you're having any suicidal thoughts and the potential implication of that. And we'll talk a little bit about how that can manifest depending on the background.
And that loss of autonomy or loss of ability to make your own decisions being taken somewhere against your will, especially for certain communities due to historical trauma around that, institutionalization, forced residential schools, incarceration, things like that, heightens the impact of that and the fear of that, as well as also for certain communities increases the likelihood that a provider will jump to that based on the way the person identifies or the way that they look in their office.
So multiple factors to take into consideration. That's why it's important as providers that you have a clear understanding of this distinction. And that can inform like next steps in terms of treatment or getting people connected to resources. All right, well, we won't spend a whole lot of time on these, but again, some of this may be a repeat in what you've seen in previous presentations, because this is a lot of well-documented risk factors for people. It doesn't mean that if someone is experiencing one or even two, that they're automatically planning to take their life or die by suicide, but they're just things that we want to keep in mind when we're assessing a person's risk. So obviously there are a number of individual factors. For example, if a person has had a previous suicide attempt, maybe that heightens the risk a little bit, and we want to be a bit more mindful of this individual. And just other factors like history of mental health conditions, hopelessness, criminal legal history. So we want to keep those in mind, but we don't want to necessarily jump the gun if someone happens to have one or more of those risk factors.
Okay, so these are also, we're kind of going through the kind of broad risk factors first, and then we're going to kind of get a little bit more specific. But these are some of the commonly documented and researched relational factors. So things like current or history of bullying, family history of death by suicide is associated with it being a risk factor or higher risk. Loss of relationships, whether that's a romantic relationship, but also friendships, coworker relationships, family relationships, relationships with important people in their lives. It's important. Sometimes when we say relationships, people automatically assume romantic and or sexual, which are also not necessarily the same things. But it's important to keep that in mind, that we are inherently relational beings. And this is something we'll get into a little bit more as to how culture impacts that. High conflict or violent relationships, social isolation, and stressful life events like rejection, divorce, financial crisis, or other life transitions or loss.
And in addition, we have other risk factors. As you can see, this can get more and more complex, right? When you take into consideration all the potential risk factors a person can present with. So if we look at societal or environmental risk factors, we're not all the same. We don't all have the same experiences in this society. And so we have to take that in consideration. So we talked a little bit about like healthcare providers, for example, and the stigma associated with help seeking and or mental illness. Now, I do think that, that's been a societal issue, but I say certain cultures have a heightened stigma with health seeking or mental illness in general. So it's important to be mindful of that.
And to what Dr. Shelton was saying, even cultures like healthcare in general is a culture, but the specific work culture of the unit, the department, the hospital, the clinic that people work at also highly influences this.
Absolutely. Okay. So it's also important to consider what kind of barriers a person has to access to healthcare, because obviously that could be a risk factor. A person that has more barriers may be at higher risk. Do they have access to lethal means? I think that's something, again, that can be a unique risk factor when you think of healthcare providers, like the data links to, for example, like physicians or surgeons certainly have knowledge of lethal means, right? So that could potentially be a risk factor for someone if you're taking into consideration other characteristics. And then again, exposure to or influence to being influenced by others who died by suicide. And then sometimes death by suicide in their local areas, clusters can have an impact too.
Those can also have a contagion impact. Have y'all heard that term? And that is why there are very specific guidelines for language, especially with media coverage, and even the way that you talk about within that specific community, suicide and the impacts of suicide, because the ways that we talk about it has been shown to be associated with that contagion impact. Okay, so if you notice, some of these were on previous slides, but we're going to get a little bit deeper. So lack of access to healthcare, okay? What are some of the cultural factors that might impact somebody's lack of access to healthcare? Inherent
That's a great one. Yeah.
trust in the medical system,
Yes.
okay? Whether that's due to historical trauma because of various things, Tuskegee. Please tell me you're familiar with that. If you're not, make a note to yourself, go look it up when you leave. For trans and queer, non-binary, gender non-conforming, gender variant individuals, historical history of pathologization of identity, it being treated as mental illness, lack of trust in the medical system in general, also influences that. So yes, any other factors y'all can think of? Distance to the hospital, and then what's another one that goes right along with that? Transportation. Yep. Okay. Yeah.
Yep.
Do you have your own transportation? Is there easily accessible public transportation? Does that transportation run at all times?
Is it close to you?
Is it affordable?
Yes.
Okay. What else? Yep. Insurance, financial costs. So insurance is influenced by so many things. We know that research shows that folks from historically marginalized identities tend to have less access to healthcare. They tend to have higher unemployment rates or have more difficulty attaining employment that would provide them with adequate health insurance.
Yeah.
Okay. Yes.
Oh yeah, that is true.
Shortage,
definitely true.
Shortage of psychologists, and I'm going to take that even further. Shortage of psychologists who speak your language,
of particular identity, yes.
Who are your, who understand your background, who provide culturally specific and informed, appropriate care. Okay. Yeah. So there's lots of different, both kind of things that we think of as societal, but that impact specific cultures and identities differently.
Yeah.
Okay. Suicide clusters in communities. Okay. We talked about the contagion impact, right? That is intensified and magnified depending on the community, the close, how close knit your community is. When we talked about some of those relational factors as well, think about people who come from more historically community focused cultures or less individualistic cultures, that impact on the community and those connections is even more important. Okay, community violence. Okay, for a lot of folks in areas of high violence, whether that's from a number of different factors, whether that's from like war, civil unrest, or that's from high violence within that community, police violence, all different types of things. Sometimes people get into a mindset of, what is the point? Or it's inevitable anyway, or they don't see a way out. Okay. Stress of acculturation. We work a lot with either folks who have immigrated to the country or their families. So like first gen, second gen, even third gen, who talk a lot about this idea of I'm straddling multiple cultures and nobody gets my experience and I'm getting pressure from all sides. And that also influences different communities and cultures' views on mental health.
Yep.
Okay. So maybe they're all for engaging in therapy or medication, but their family, that's not how they view those issues. Maybe they view it through a more like community care lens. Maybe they view that through more of a religious lens or a community healing and like traditional healing practices lens. And so that becomes difficult sometimes. I mean, difficult in a lot of situations to walk that line. And we tend to, and I say we as kind of healthcare providers, we tend to prioritize a very white, upper middle class, masculine, cis het, Western view of what is the best treatment. Yeah. Okay. And so if someone comes into us and we're not acknowledging their cultural views on mental health or health in general, their community traditions around healing, if we dismiss those, that's just going to increase that community's, sorry, I'm pointing at you, but it's going to increase that community's distrust. Yeah. Or lack of willingness to engage fully or authentically, because you just dismissed a huge piece of them or their line. Yeah. Okay. Historical trauma. So, are you familiar with epigenetics? Okay. If you're not, another term to take a note, go home, do some research. But there is a lot of new research coming out showing the impacts generationally of trauma. And when we're talking about certain cultures, sometimes that's still impacts of enslavement, because enslavement did not end that long ago. Okay. We're talking about historical trauma of forcible dislocation from lands, forcible institutionalization, residential schools, missing and murdered Indigenous women. All of the stuff that has come out in the last few years about the trauma at Indian residential schools and child abuse and forced isolation from community practices. These things live in communities and they live in individuals and they continue to impact. And then discrimination. Like, this is both on an individual level and on a huge systemic level. Okay. I'm a queer non-binary person. I have a non-binary child. I work a lot with queer and non-binary folks. A lot of us are very scared right now because we don't have access to our healthcare, or our children don't have access to our healthcare. We're having to think about, can we relocate and change states? Are my children going to be safe? I held my 7-year-old while they cried and bawled to me because they were afraid to use the bathroom at school. 7 years old. Okay. These things are not isolated. They're happening every day. And it's important to look at the culture and as a whole of the United States, but also where we are. We're in Kansas and Missouri. There's a long history here of a lot of different things. Racism, Indigenous, violence against Indigenous communities, trans exclusion, LGBTQ history, or LGBTQ discrimination. Like, we don't have statewide protections in Missouri. We don't have statewide protections in Kansas. So it's important to look at all the things that people are living in, because these are going to influence
And as we progress, we are going to talk even more specifically about how are we going to incorporate that in the work that we do with people and the intervention that we do with others, and just the support that we offer people, because you can't really remove this when you're considering all of the different factors that can come up for a person.
Okay.
So to that end, and I think Dr. Moran spoke quite a bit about this.
I got a little ahead of myself.
So as you all can get the impression of now, we have to take into mind those cultural considerations when thinking about risk factors, because it varies. It's not a one size fits all. So risk factors vary depending on the age group, the culture, sex, other characteristics. And we've talked about examples of different types of cultures when you're thinking of healthcare providers. All of that is going to contribute to just a variety of what that risk may look like. So yes, it's important to keep in mind all of these factors, but it's also important to keep in mind who's in front of you. Like, who's in front of you? What do I know about this person? What is impacting them? And especially in terms of if they do like report suicidal thought ideation to you, what could be influencing them? What cultural factors could be magnifying their risk, or what cultural factors could be protective for them? And we'll talk about that too in a few, because they can be both. They can magnify risk or they can be a protective factor. Okay.
And cishet white guys do still have cultural impacts on them. I don't want to ignore that. I want to acknowledge it. For example, especially in middle years, those ideas of kind of traditional masculinity and masculine roles of provider and things like that, all that kind of 50s and 60s a man in the gray flannel suit type stuff, is associated with some of those higher risk factors for men in the middle age years.
Yeah, definitely.
Okay, so to start to look at some of these things, there was kind of a number of researchers, including Joyce Chu, who looked at how culture influences suicide risk, suicide protective factors, as well as presentations of suicidal distress and how we can influence that. And they developed the cultural model of suicide risk and protective factors, or cultural model of suicidality. So they identified 4 major categories of culturally specific risk: social discord and minority stress. So we've already touched on these in a number of ways, but these are important factors in what may be behind somebody getting to a point of experiencing suicidal ideation. Okay. And then cultural sanctions. Cultural sanctions, it refers to kind of those messages or ideas within a specific cultural community or background about the acceptability or not of suicidal ideation, mental health, things like that. In communities in which suicide is seen as a more acceptable option, that influences things in a different way than communities where suicide is seen as, for example, a sin or something horrible that a person could do. It doesn't necessarily mean one impacts it in a positive way and one in a negative way, but it is important to think about, because you can use that then for how do you move the person through this. And then idioms of distress. This is basically, how does it present? Okay. Not everybody's going to come to you and say, I'm having thoughts of suicide. Okay. But there are different ways that that distress is expressed within certain communities or certain backgrounds. Once again, this is going to differ from person to person, but it's important things to keep in mind, because there are certain kind of flags or buzzwords that might be like, okay, I need to go a little bit deeper. And so we've started talking about kind of the social discord and the minority stress, and we're going to kind of work through the other 2, but I just kind of wanted to highlight these 4 factors.
And a way to kind of look at this is when you're considering all the potential risk factors that a person presents with, this kind of gives you a bit of a guide of how you interpret that, right? With taking their cultural identity or multiple identities in mind, right? Okay. So burnout plays a role. And again, this kind of goes back to when we were talking about healthcare providers and those unique risk factors, right? Healthcare providers or students in healthcare fields, residents, fellows.
Veterinarians.
Yes. So burnout plays a role, and that might be a unique factor amongst certain cultures, certain populations, right? So this is the data that, gives us an indication of the impact of burnout. So 50% of students experience burnout and 10% experience the suicidal, of those 10% experience suicidal ideation, right? We see it in, like I said, medical students, residents, fellows, physicians. We also see it with nurses.
Nurses with symptoms of burnout were 2 times more likely to experience suicidal ideation. That was as of research in 2021. I'd be curious to see it now.
Yep.
Some research that was done with veterinarians found that burnout seemed to be kind of one of those mediating factors between difficult work conditions and suicidal thoughts. So the presence of burnout, if they were feeling burnt out, if they were experiencing symptoms of burnout, then it was much more likely that they were going to have thoughts of suicide. And I'm kind of going to go over this relatively quickly, but it's also important to look at culturally infused magnifiers. So we know that job loss, for example, is something that is associated as a risk factor for suicide, right? Okay, but if you think about the fact of if somebody is an immigrant or not, their legal status, whether they have higher education, whether they have the financial resources to be able to find another job or provide health care if they lose their health insurance. If it's an immigrant mother of a medically fragile child who just lost their job and now lost their health insurance, those cultural factors are going to amplify the risk factor of that job loss. Okay. Intersectionality, another one of those terms. If you're not familiar with it, jot it down, look it up later. But it's the idea that our experiences of any one part of our identity are influenced by our other identities. So one person's experience as a woman is influenced by their other identity factors. Okay, so this is that idea of those infused magnifiers.
And kind of the key take home is it can magnify a person's risk, keeping that in mind. Okay, and so this kind of goes back to what I mentioned earlier, right? We want to be mindful of protective factors, and these are kind of the protective factors that have been well documented, well researched, and generally speaking offer protection against that risk. But it is also important to keep in mind that certain factors could also magnify the risk. So, different internal and external resources. I certainly won't go through and read all of this, but for example, does a person have good problem-solving skills? That can be a protective factor for them. Do they have positive coping skills? Have they developed that? That could be a protective factor. And that could be a focus of treatment too. That's something that you could help them build more.
Spiritual beliefs.
Yeah.
That for some folks can be a protective factor. But it's also important to realize that may, when taken in intersection with the other aspects of their identity, might actually magnify risk. Yeah. For example, if they have loss of access to those spiritual beliefs or to practicing those spiritual beliefs, if they have disconnection from their spiritual community, if they feel ostracized or not accepted within their spiritual community because of one of another identity factors, or if their spiritual community tends to see mental illness or thoughts of suicide in a very negative light. So it's important to look at for this individual and their constellation of identities, how does this play in?
And that's an example of an external resource. Family is another one, right? For some people, family could be a protective factor, having a lot of family support. It could also be a magnifier. For some people, family is not a safe space. So we really have to identify what that means for the person. Okay.
What time did we start? What? Okay. Okay.
Okay.
Okay. So we'll go through this kind of kind of quickly, but we talked about this. There's research that shows having strong ties to one's cultural background or like positive identification and like solid positive racial or ethnic identity tends to be a protective factor. Yeah. Having strong ties to a cultural community can also strengthen those social networks and those relational connections, which is one of those protective factors. Like I said, cultural, religious, or personal beliefs that encourage connecting and help seeking, discourage suicidal behavior, or create a strong sense of purpose within people tend to be protective factors.
Why don't we skip ahead a little bit to like what we're gonna do?
Okay.
Yes, how do we help?
Okay. Yeah, it's just one thing that I do want to highlight really quickly. Some of the kind of culturally specific suicidal warning signs might be things of feeling like a burden to others, feeling like a burden to your family or your community is one of those ways of expressing suicidal ideation in a less direct way. Yeah. Not having that sense of purpose or doing reckless things that put you in danger. Yeah. That is often associated with communities in which suicide is not seen as okay. So I'm going to put myself in risky situations. So there's essentially like plausible deniability if something happens to me.
And we also want to be mindful of the way suicidal symptoms or methods are expressed, because not everyone expresses it directly, right? So there is like the hidden suicidal ideation. They may not directly say that they're having suicidal thoughts or they're thinking about suicide, but it may, you know, look like something else. It may be a different phrase, or it may be a tendency to just minimize or downplay that distress. Okay.
And those things are important in how we connect, how we assess, and what we do with it. So that's why we wanted to highlight those. So we really see, especially culturally informed suicide prevention, kind of the steps is to make a human connection, connect with them on a human level, which is going to be influenced by a number of different identity factors. You're going to ask directly about suicide, but once again, that might be a layered question process to get through the initial defenses or that initial, I can't acknowledge that because it's not okay within my community. You're going to encourage them to seek help, provide resources, and it is important that those are culturally responsive and appropriate resources for that person. And then increasing connections to their communities, to others. The more human connections they have that are positive in their life, the better the outcome, okay?
So a few things to keep in mind about making a human connection. You know, you want to be genuine, be sensitive, be genuine, be sincere. You want to use active listening. You want them to know that you're hearing them, not necessarily thinking of your next comment or making a statement, but that you're really hearing them and trying to understand their story. And doing things that help build rapport, like you want to acknowledge or normalize what emotions they're experiencing, express your care. You know, don't question the reality of things. Don't give them the kind of empty platitudes. You just want to say, I'm here, I'm present, I'm listening to you, I hear you, right?
We need to be mindful of cultural differences in trust, communication, authority, and interpersonal styles, whether that's space or how I'm relating to you, the different power differentials in the room. Active listening oftentimes says maintain eye contact. Okay. Depending on cultural background or, for example, autistic folks, we don't, like eye contact can feel very uncomfortable. Yeah. But there are other ways, or disrespectful.
Yeah.
So there are ways to communicate that you are actively listening and engaged, even if you are not providing direct eye contact, and even if they're not as well. Yeah. Okay.
And we won't go too into detail about
this. This was a lot of the same stuff that was covered previously.
Yeah, we want to continue to be very direct in asking about suicide. Actually, can you go back? Because there's something I want to highlight about it, because, and it may be on this slide or another slide, but
I think.
With certain cultures, asking directly about suicide can evoke shame. And you want to be mindful of that, especially initially. Yes, at some point you do want to be very direct about using that term, but initially when you're making the connection with individuals, recognize certain cultures, that brings up a lot of shame. And then we get into the territory of the hidden suicidal ideation, where the knee-jerk reaction is, oh no, I'm not experiencing that, or downplaying, minimizing, or denying. So we want to be mindful of that given the background of a person. So some examples of different variations to how we could maybe want to ask that. Have you ever wanted to give your life away?
Have you ever felt like you don't deserve to be alive?
Have you felt so ashamed that you wanted to disappear?
Or that your loved ones would be better off without you?
Yeah.
Have you ever felt like your time on earth is done?
Yeah.
Or this world has rejected you and it's time to leave?
Yeah.
And then depending on their responses to those, you validate, you stay that human connection, and then you can get more specific.
Yeah.
Because that human genuine connection and the starting where we're not trying to immediately evoke shame and evoke that fear-based response, then they're going to trust you a little bit more, most likely. Okay. Be direct with suggesting they get connected to help. It's not a one and done conversation, but also be aware of what those resources are and what ones might not be appropriate for your person.
We also want to be mindful of if a person's in immediate danger versus they're not. Obviously, if they are in immediate danger, you want to stay with them. You want to assist them with calling 911 for emergency services, or other mobile crisis services. But if they're not in distress, don't want to push too hard. Again, taking consideration who you're speaking with, you want to offer and provide them with resources. You don't want to engage in behaviors that's beyond the scope of your qualifications and your ability. So you don't want to necessarily engage in safety planning with them or, something like that.
If they are in immediate danger and you do have to invoke any sort of active rescue efforts, be transparent with them, let them know what is going to happen and give them as much autonomy in that context as possible, especially if they are from communities where they have identities that have that historical or current trauma associated with things like uniforms, police officers, those in authority, things like that. You may need to use those resources, but trying to be as transparent and let the person know what's going to happen helps not kind of escalate the situation unnecessarily.
And basically the point with that is you want to help them get connected. And that's you being aware of all the different resources, providing that to them. Some people may check out resources on their own just so they get a sense of how that process goes and how to advise them. Okay.
I know we're pretty much out of time, so I'm going to go over this very quickly. So 988, obviously great resource, but did you know that they also have specific veterans crisis resources? They have chat, text, and things like that in Spanish and in English. They also offer ASL services. Okay, so you can do ASL video chat so that you are able to talk in your first language or in your most comfortable language. We also have a number of community-specific resources that are out there. And there are a ton of them. I'm going to pause for a second. So if you want to take a picture, you can. You can also you can also send either of us an email or reach out to one of us. We will provide the link to those resources, or they're in our PowerPoint if
you have access
to that. But there's a ton of great ones, including ones that either offer multiple languages, have translation, or for example, Asian Life Net Hotline specifically offers services in Cantonese, Mandarin, Japanese, Korean, and Fujianese, because it is important, especially when accessing things like this, that people are able to talk in the language that they feel most comfortable in, especially when we're talking about more abstract or emotional concepts, if that is possible. Here's the second one. And notice there is a physician support line. So there's a crisis line that is specifically staffed by volunteer psychiatrists, available to talk to med students and physicians. There's a specific one for grad students. There is Don't Clock Out, is specifically, they have weekly virtual free support groups for nurses and bedside staff. Thrive is for individuals in STEM with at least one or more marginalized identity. So there's a lot of really great resources out there that you can connect people with yours. It's important to note that Thrive and Trans Lifeline do not engage in non-consensual active rescue efforts, which for some folks means that they are more likely to call. Okay. Obviously, there are feelings on all sides of that, but wanted to let you know. Yep.
And there are plenty of online resources as well. So we specifically have some through KUMC, through the KU Health System that, you know, again, reiterates a lot of what we shared here and has additional resources. But there are also a number of helpful apps too that I think are important to highlight. I think the Virtual Hope Box app was highlighted earlier, Be Safe Act, Suicide Safety Plan Act, Stanley Brown Safety Plan Act app. And these are important resources that you can provide to someone that will help them really come up with their own safety plan and resources.
And if you are a mental health provider who wants more specific drilled down training in safety planning and assessing suicide risk that incorporates culture, there is a training offered through Community Connections. It's called Suicide 2.0.
Oh, you're talking about the advanced. There's the Be Sensitive, Be Brave, and that's kind of an introduction, and that's for anyone regardless of your background. But then there's the Advanced 201 training, and that's specifically for mental health professionals if you're wanting more advanced training on not just suicide prevention, but collaborative safety planning, documentation, and then treatment. Okay. All right.
Sorry, I know we went over a couple minutes. I apologize.
And I don't know if do we have time for questions? Sorry. Okay. I think we have.
I would just like for you to repeat the last about the collaborative safety planning. What is that called again?
So that is through the company called Community Connections, and they have an advanced 201
2.0
or two.
or is it 201?
It's 201.
Oh, yeah,
Advanced
201,
201 suicide training.
No, there is a cost associated with that.
With both of them, actually.
With both of them, yeah. But it does provide CEs for mental health providers. It is a great one, and it's actually done by Joyce Chu, who is the researcher who created who is one of the creators of the culturally informed or the cultural model of suicidality.
And it goes into specific details about the collaborative safety planning, how you want to document risk, take into consideration static and dynamic factors, and treatment, depending on who's presented in front of you. So.
I've often found that when assessing someone for suicide, the level of comfort or discomfort with those thoughts gives you something to get started on.
Yeah.
The other factor is from a cultural standpoint. Since I supervise residents, if the resident is the first one in the family to achieve that status, but their culture is one of the male head of household is the final say, or to be polite, it can be a hindrance and a stumbling block for them.
Yeah.
I started out in child psychiatry. One of my first patients in training was an 8-year-old boy. He was white. His father was 25-year military, French-speaking part of Louisiana. That man could not call me doctor to save his life. And the kid was stuck between us. The kid couldn't even play with black chess pieces. That's how hard it was. So my work was not only on his anxiety and depression, but being okay with me.
Yeah. So yeah, thank you. Yeah, that adds a different layer to it, right? That we, certainly couldn't touch on within this, but obviously we take in mind the cultural factors of who's in front of you, but we also have to take in mind ours, like who we are in that space and how that impacts potentially
How
our
we view
interversion.
these
Yeah.
things, how we think about them. I did not mean to interrupt you. I apologize. But also the stimulus value that
Yeah.
we bring.
Yeah.
And how that's going to play into the relationship.
Absolutely. All right.
Thank you
Well,
so
thank you so
much.
much.